Hello, this is Henry Salama for Dental XP TV in Philadelphia in Lou Rose's office. A very good friend of mine, a teacher of mine, a colleague. We practiced right next door to each other for 10 years, from 86 to 96, before I went down to Atlanta. And it's a great pleasure, Lou, to be with you again and to spend some time.
Thank you very much. The pleasure's mine.
What I'd like to do, you've been involved in so many aspects of periodontology, from as a teacher, involved in the academy. You've certainly seen it over several decades. Where do you think periodontics is going? There's some concern that possibly implant dentistry has possibly made periodontics a little bit of a vague specialty. Are we going to continue with it, especially for the young periodontists out there? What would you be saying to them?
You can say that periodontics is really a specialty in transition. A lot of evaluation going on regarding what our role is, but Henry, I'll tell you, implants certainly has had a major impact, a very positive impact in periodontics. On the other hand, we're still saving teeth. And that's our primary goal. That's what we always did in the past. But now we're into the area of regeneration. I mean, you still can save teeth. We'll be growing teeth at some point. But the regenerative materials are unending in a sense. I mean, there's a lot of research going on, and the ability to grow bone, to grow gum tissue, it's going to be another boom for periodontics. So we're not going anywhere. We're going to stay put, and I think make a major contribution in the whole biological aspect of dentistry.
There's a talk possibly that the Academy is looking to allow certain restorative procedures to be included within the specialty or within the curriculum in postgraduate education in periodontics. Is that true? Is that the trend? What do you think about it?
Well, you know, Henry, you went through the Perio prosthetic program at Penn, and you guys learned how to do not only restorative dentistry, but an excellent education in periodontics. And many of you guys do just about everything. You do restorative dentistry, periodontics, endodontics, and that really, you were before your time. I mean, today, periodontists, in a sense, should be learning restorative dentistry, and many of the programs are now incorporating it as a requirement. The education definitely is going to change, and periodontics will become a form of periodontal prosthesis.
In building your practice over the last few years, have you seen that the way you're promoting your practice, your referral base, is it any different than it was, let's say, 15 years ago, 10, 15 years ago?
We're seeing different kinds of cases. 10, 15 years ago, you were doing full mouth periodontics. And today, a lot of it may be what we call prescription surgery, where we'll be doing maybe soft tissue augmentation procedures, regenerative procedures, and the general practitioner is, in fact, dealing with infection control. I think that, if anything, the powers that be in the AAP and so forth are looking at emphasizing infection control again for the periodontist to focus on. It still is the basis of saving a tooth and or repairing or regenerating different types of tissues, and you can't do any of that until you get the infection under control. So now that we know and that we're talking about a chronic inflammation, that we're talking about chronic disease, and the numbers of risk factors that exist, it requires a specialty. I mean, there is enough education and there are enough procedures that require 3 years of education, 4 years of education beyond dental school.
Fantastic. Just to finish up, if there's a tip, a tool, a component, a technique over the last year or two that's changed the way you actually practice, what would it be?
Well, certainly I could identify a couple of procedures, but what I think is absolutely imperative that every dentist really understand the oral systemic link. It has changed the way we look at a case. It has changed the way we diagnose a case, how we treatment plan a case, the emphasis on a thorough medical history, identifying those patients that have cardiac disease or diabetes to the degree that they have it. We now know through research that both diabetes and cardiovascular disease are affected by infection in the mouth, particularly severe periodontitis.
So in a sense, we're affecting the overall health of our patients, not just their dental health, but overall health.
Absolutely. And I don't mean to overemphasize the point, because there are a lot of dentists out there that, will say to a patient, you better floss or you're going to die. And that isn't the case, obviously. The important thing to know is that the research shows an association. At this point in time, we don't know if there's a cause and effect. In other words, if we treat periodontal disease, will we help the diabetic, or will we help a cardiac patient? All the research says probably yes, but we still need to do some real good intervention studies to make that connection. But keep in mind the fact that periodontal disease is a preventable disease, a treatable disease, so why not treat the infection? Even if the association may be weak in some people's mind, it's still a treatable infection.
Are you using more chemotherapeutics, whether systemic or local, to augment? Are you finding that you're doing that more so these days because of the aspect of treating the infection for the patients?
If you ask me personally, I really haven't been that impressed with some of the local drug delivery systems, because if they act the way they say, the companies say they do, well then you have to realize it's a short response to the antibiotic in time. You'll get back the inflammatory process unless you remove the etiologic agent, plaque. So it takes us back to, you still have to do the very best you can in root planing and scaling, and all these other local drug delivery, systemic drugs are adjuncts. And I think that there is in the near future going to be drugs that we will be able to use to prevent periodontal disease. But as of now, I'm not that impressed with local drug delivery.
Is there anything down the road in terms of bone augmentation, growth peptides, active components that you see that will change periodontics in a particular way? We've been hearing a lot about BMP2s and so forth. Are they going to be here soon, or
they are here?
I know they're here. But whether we'll have them or not.
Yeah, I know. Yeah, I mean, I would believe that in the next 5 years, we're going to see materials like that include bone morphogenic protein, growth factors, and so forth. We will be able to say regeneration is a clinically predictable procedure. There's no question about it.
Lou, it's been a pleasure. Thank you so much for your time.
Quite welcome.
I mean, it's always a pleasure to hang out with you outside of this anyway, but I'm sure everybody will enjoy this, and let's do it again sometime. Thanks a lot.